I'll just stay right here.
Yeah, okay, I'll just, okay.
Josie, push.
I can see the works.
So, hello, I'm Ruth Sheps and I'm the co-director of the Centre for Population Health and Public Health Research here, and this is a seminar that we've got together on behalf of that centre, and we're so lucky to have Pam's actually just over visiting from Ohio, and we wanted to meet on another reason, so I thought, well, I'll just bring her up to Stirling because she's in Edinburgh for a few weeks, so I think it's really great. And so Pam is a professor of nursing in Ohio. She trained as a nurse, but like me, she's not a nurse any longer. I wouldn't want to help you out. She's also assistant director of the Institute for Population Research, and Pam does a lot of work on sort of intergenerational research, looking at things like childhood obesity, health inequalities. Is that right? It's a whole load of different things. So I'm really excited about hearing about this longitudinal project and things. And yeah, I'll just hand over to you, Pam. I think in terms of, you just use the mouse or these buttons here, is that all right? And I think the microphone's there, but okay, it's up to you. I think as long as you shout.
My voice generally carries, so I think it'll be fine. So my talk, I think as you've seen advertised, is maternal influences on child health and well-being. And I'm going to talk for the latter 3/4 of this, mainly around an intergenerational data set in which I've used over the last 8 to 10 years to try to understand child health in particular as it relates to what's happened in the mother's own life course. You know, if you have questions along the way, I'm happy to just have a conversation. That would be great. Or, I don't know, Ruth, since we're recording, would it be better to save questions to the end?
I don't think it matters. We can do it either way. I think
Okay.
sometimes it's useful for people to know what questions there are as well.
Okay. The other piece of I didn't put on here, and I would love to talk if there's PhD students here. I also direct our PhD program in nursing at Ohio State. So if there are PhD students here, a particular welcome to you. They really are the important part of our future. So here I just wanted to say greetings from Columbus, Ohio, and Ohio State. This is our center oval for our university, and it's probably appropriate, though when I put this up here I didn't know it, that it's snow covered. We received 5 inches of snow yesterday out here from my husband, so I'm glad I'm actually not in Columbus. It's better weather here than in Columbus. So this is a view that looks out over the campus from our library. Just wanted to sort of give you that snapshot. So I'm going to walk through just some motivation so you have some context to understand where I came from to this work that I've done over the last 8 to 10 years. So first and foremost, as Ruth said at the beginning, these questions arose out of clinical experiences, and those of you who are clinicians, I think, will understand that, though it may feel that I'm sort of far removed at this point in my career from the sort of clinical bedside. But I very much am always informed by those early sort of formative years professionally when I spent with patients and tried to help patients achieve improved and healthier lifestyles. So again, pretty much from a base of clinical experiences, as well as really driven by issues more from almost a moral perspective around social justice, that over the last 10 or 15 years, both in my own thinking as in the thinking around the world, and UK has in particular been, I think, at the forefront of this thinking throughout and influential in the US in the way they think about these problems. I think it's much more natural for the people in the UK and Scotland to think about health inequalities and social justice. We're, again, still trying to get there. But my work's been driven by this sort of question for really, I would say, for the last 25 years. My colleagues find it shocking when I was going back to my clinical experiences. I started out in the early 80s, but when I started out in the early 80s as a staff nurse at a large institution, it's hard for them to believe that I really started out when wards were still segregated. It was a pretty wide period from civil rights, but it was supposedly segregated by income, but it was almost completely segregated by race. And so I started out on wards that were primarily, if not entirely, African American and low income. So I started out in Cleveland, Ohio, which is in particular high poverty areas. So again, that's sort of where I came at this and where I'm from my interests. And you'll see how I've progressed to where I am now, but I'm very interested in early life and early life disadvantage, and begin to switch now my thinking about how we can think about resilience and what happens in that 0 to 5 age and with maternal advantage and mitigating risks. I think we need to sort of shift from sort of the bench science. We know a good deal about what's happening now, and how do we begin to mitigate or improve the chances over the life course of kids who start out at high risk. And so hopefully we can have some conversation about that. I'm really interested, and one of the reasons I'll say later, I'm intrigued by how embedded early life is within the Scottish government, and so that's sort of one of the things that have drawn me here, just to sort of listen to how that's gotten so much into the policy arena here in Scotland. So before we begin, though, I want to say there's one major difference between the UK, in particular Scotland, and what we in the US are faced with when we talk about health disparities and health inequalities. I think, though I may be wrong about this, health inequalities in the UK and Scotland really have much to do about socioeconomic class differences. Ours really have to do with both. So it's a very complicated picture in the sense it has to do with socioeconomic differences, but it also has a lot to do with race. And I'm not going to talk a lot about that, other than I want to just sort of highlight a couple numbers here that begin to show you what the problem is. So there is a life expectancy difference in the US by black-white differences. And so these data are a little old, even though it comes from a very nice paper by David Williams, who is a sociologist teaching at Harvard. It's a paper called "We Have Miles to Go Before We Sleep," or something catchy like that. But it's an overview of where we've been and where we've got to go in terms of health disparities. So at 25, the life expectancy for whites is about 53.4, and for blacks it's 48.4. And if you carve these into gender differences, it's going to be a little starker than this, but there's a 5-year gap in terms of life expectancy. If you look across income, we have the same sort of thing that I think you would find in the UK. We have a pretty wide gap between those, and what we have is the federal poverty line. There's a gap of 6.8 years. And so the gap actually in economics differences is greater than this racial difference, but it's still a pretty good gap. And notice the gap for blacks is doubly worse. I mean, in the sense that they've got a gap now of even greater than the 5 at 7.1 years. And so any work that we do in the US around inequalities and health disparities has to try to take into account both economic and race. And there's been a lot of work in the last 10 to 15 years to try to figure out if the racial differences are simply a function of economic differences. And so how do you tease apart differences between race and economic differences? I think most people working in the field agree that it's likely, there's likely a racial disparity difference on top of economic status, and so that there's a cost to one's health in the US for discrimination, and there's lots of reasons that we could have a sidebar conversation about this. It has to do with the way we still are very segregated in our housing in the US, which then leads to very segregated schools, and those schools tend to be in poor areas, which have, the students come to school less ready to learn, with poorer teachers, and so their long-term life chances are really stunted from the very beginning. So we really, as a country, really struggle with this. So a lot of our discussion about health disparities in the US has to do with race differences. Interesting, we also have a large Latino population, and the Latino population, even though is quite poor, is in better health than African Americans. The other question, as we think about intergenerational transmission of health capital, the other interesting questions of work that are being done by a lot of folks in humanities, which is quite interesting, around, in particular historians, about the effects of slavery. Again, a good portion of our African American folks have at least some history in slavery, and there's some questions about selection from an evolutionary standpoint in terms of, and how many generations that cuts across. And if you're thinking about generation work, which is what I think about, in the US, the civil rights laws weren't passed until '65. And the cohort that you're going to see that I use actually was born before that. So we always have to try to think very broadly, not just about sort of sociological and health issues, but historically in terms of what these individual lives have been when we try to explain or think about health disparities across the US population and try to take into account this additional burden that African Americans seem to have. You know, we really struggle, for those of us in the sort of broader social science areas, to try to help, I would say, some of the more medical or biological folks who want to jump automatically to sort of an explanation of genetics. We really struggle with trying to help them understand that social context matters, and social context over many generations matters, and that it may have epigenetic but probably not genetic differences. And so again, all of these struggles, you should be thankful as researchers or practitioners that you're not sort of challenged. But everything that we do as US researchers, we have to sort of think about this. So the framework, and I'm not going to spend much time here because you know this probably better than I do, has been very much influenced by, and I put Marmot's work on the White House studies, which has gotten, as I said, it's very influential in now work in the US in terms of what that found. And it has led to sort of various versions of the social determinants model. Again, I think probably everybody in this room is familiar with this. This is actually the one that drives the CDC, which is our Center for Disease Center, drives their Healthy People 2020. So this is the overall model to drive our overarching goals relative to determinants of health. And for those who aren't quite sure of the structure in the US, the CDC really is the area which has been tasked with public health for the most part. NIH is our big funder for research, but it's really driven, not exclusively, but a lot by molecular and biological work. We continue, for those of us in the social science, try to influence a little bit of what NIH does around social science. CDC tries to do that. But this, again, is not a model that you're unfamiliar with. But again, it is in the US system around the CDC. So I'm going to now jump and talk about what I'm calling a family of studies that I've been involved in, so you can sort of understand the data set. And I'm not going to spend a lot of time going through specific studies and lots of detail about numbers. I just am going to give you a general overview of this and then some findings and with some ways in which this thinking has evolved. But just to give you enough so that you understand what this data set is. The data set's called the National Longitudinal Survey of Youth. It's the 1979 cohort. There's actually one that began in '97, so there's a parallel one that began about 20 years later with this sort of same purpose. The birth years of this cohort are from 1957 to 1964, so as I said, these people were born just at the cusp of the civil rights era, for those who are, I mean, for everybody, but those African Americans, who also, if you think, and this is what I've really had to sort of train myself to think about in the last 5 or 10 years, and it's not intuitive, I have to think about where the sort of mothers and fathers of this birth cohort were, because trying to understand intergenerational transmissions, those mothers and fathers were clearly formed at a time when the U.S. was a very segregated place. The data set has been sponsored by the U.S. Bureau of Labor Statistics, and you might say, well, that's an interesting place to have this be sponsored by. Well, the survey actually began as an attempt for the Bureau of Labor Statistics to enroll a group of essentially teenagers in 1979, so with these birth years, so that they could follow them over their life course. And what their interest is in their labor market participation. So they want to know how people enter and exit the labor market, what kind of impact does fertility births have on especially mothers, but also fathers return to work. They're now interested in how, because these folks are still being followed, they're in their 50s, they're now beginning to ask questions about how they're going to transition to the next phase of their life, though retirement ages in the U.S. have been pushed out. Now it's not something that's done in their 50s for the most part. So they wanted to understand labor market participation. They also wanted to understand a little bit about health impacts that participation in the labor market. And interestingly enough, they had, in 1979, they did have the forethought to oversample a large number of African Americans. So the data set itself is unique worldwide in the sense that it's now a data set that has got a wealth of information. I think on the next slide. And so I'm going to talk about the women. It has a wealth of information really about social contextual issues. So it has a lot of information about household rosters, who's been in, who's been out. We have addresses for these folks now for 50 years, or since 1979. We know where they lived. We have a residential history on them back through birth, and so we can know now over 50 years where they have lived. You might say, why do you? So there's lots of reasons why we care about residential histories, not the least of which is when you have lots of movement and chaos in residential lives, that has an impact on both the individual and on the family. Housing information has been geocoded, though you have to go through lots of hoops to get that. That is, that you can locate these individuals within their census tracts and begin to understand the kinds of neighborhoods they've lived in. It has what I think is a complete set of understanding of data that allows you to have a complete understanding of their economic status. And those of you who are involved in this work know there's lots of controversy over what the right measure of economic status is. Unlike the UK, we don't have deprivation indexes that tie you to certain particular areas. There's lots of ways in which we've tried to come up with make-believe deprivation indexes in the U.S., and it's not been very satisfactory. So again, you're ahead of the game here. But on these people, we really can understand what not only their income has been, but what their assets have been, and not only cross-sectionally, but over the entire lives. And so part of what we're allowed, we're able to do, let's say when I get downstream here a bit on children's lives, we can look at economic status, but we don't have to look at a one cross-sectional income. We can look at the kind of poverty they've been exposed to, let's say, their entire 5 years or their entire 10 years. We know what the assets in the home have been. And particularly again, and I can only speak to this in the US, this is a particular issue when you look across race, because even at the same income level across blacks and whites in the US, there's a very different picture of the assets that have been accumulated across race. So you can have what appears to be two individuals equal on an economic status with the same income, but very different collection of assets or wealth. And as we look at what matters to health, because at the end of the day, I'm very interested in how these things play out for health, wealth becomes more important than income. That is, what kind of resources you have that can get you over a particular issue or problem is much more important in terms of your asset collection. And for most of us, what our main assets are home ownership. And home ownership rates are much higher in the white community than the African American community, so that's where a lot of the asset difference is. And then there is some health data, thank goodness there is some health data in this survey that's allowed us to begin to ask what I think are some pretty interesting questions in a different way. So I said there's about 11,000 people that they enrolled in 1979. I've done nothing with the men. So I really can't speak to what's happened with the men over this particular year because I've been interested in the women and children. That's not to say there are other people that have been much more interested in what's happened in the men's lives, but I've been interested in what's happened in particular to the women's lives around health and around their children. So the women started with these interviews in 1979. And then there was another group of researchers in 1986 came in and said, wouldn't it be great if we could begin to interview the women in this survey about their biological children. So NIH funded a very large, longitudinal, continues to go on today, survey of the children born to the women of the NOSY 79. At that point, it also funded a set of questions around fertility for these women. You know, for the midwives in the room, it's not going to be very, you're going to say, we want more. But what we do have is we have birth weight, birth length, gestational age. We have questions that have been answered about risk behaviors during the pregnancy. We have information about weight status, weight gain. So we have a history of that begins on these children with the interuterine time, and remember we've got data on these women for the most part before they became pregnant. Okay. The women were interviewed yearly until 1992 when the survey went to every 2 years. There is now thought, because of budget constraints in the US, that the survey will go to every 3 years. For the first 25 years, the survey was all done in person. That is, people knocked on doors and went in and did face-to-face interviews. Around the end of 1990s and 2000, the interview became both computer-assisted and telephone interviews. The children were never followed every year, unfortunately. They were only followed every 2 years. But for again, up through about, I think, 2000, 2002, there were home interviews done on the children, and there were observational data collected by these interviewers about the home environment. So again, a rich set of data about the sort of context that these children grew up or are growing up in. I didn't put on the slide, but I should mention that when the children turn 10, there are a series of questions that are asked specifically of the children. That from 10 to 14, the questions are asked both of the mother and of the child, and at 14, the mother's no longer interviewed about the child. It's a young adult survey, and the child then continues to be interviewed. So we've got a group now of young adults that are in their 20s, that we have, essentially data since birth. My colleagues and I are trying to put together a proposal right now that will look at third generation, because some of the kids have had kids. And so we're begin to try to think about, is there enough data in here that we can ask some important questions that we can get some meaningful answers. So we're sort of working on that right now. We've got, again, self-report information about infant feeding. Did they ever breastfeed? Is pretty much, there were questions in there about how long, but it turns out the data is not very good. It's missing. So when we use breastfeeding, it tends to be a dichotomous variable. I know it's not the best, but we tend to use it as a dichotomous variable. Most importantly is that we have this home observation tool, which is a pretty well-developed, well-known instrument that goes into, that is standard collection, that really asks the mom as well as interviewer observations about what's happening in the home. So one of the subscales that I will talk about at the end, just briefly, because I'm really trying to get in at this, and part of my interest, I think, in talking to folks who've done some work with the GUS. You know, we have questions on there about the mother's responsiveness to the child in the interview situation. Now, there's lots of problems, I understand, with that in the sense that it's an interview situation, it is done in the home, but there are data that are collected around, is the mother responsive, do they respond to the child, do they show positive emotion or positive warmth towards the child, do they kiss the child while the interviewer's in the home? Again, trying to get at some, what we now see in the literature coming out is sort of nurturing behaviors. They also, you know, not only is there some self-report data about how you discipline the child in terms of spanking or slapping, but there's also places in which the observer can know whether or not they observe those sorts of things while they were in the home. And again, we have this not just at one time point, but for some of these kids, we have this instrument having been delivered. We've got data on 6 to 8 of these over the course of this period. The challenge, actually, to some extent with these data are methodological challenges. And do we have the right set of methodological tools to even do some of this analysis? The other thing that I haven't mentioned, which complicates the analysis, is that we have siblings. So we have all of the children born to the mothers, okay? So we've got siblings within this, which complicates some statistical assumptions about independence of observations that we always have to take into account. So in some sense, the methods have had to sort of catch up to the data set. And I have, at the end, I do thank my collaborators, but one of my collaborators is an economist. And it turns out economists have had to deal with these kinds of data forever, and have had, in ways, much better, I think, than those of us who learned our statistics over on the medical side, have dealt much better with these issues about these long panel data sets. So anyways, she's really been influential in how these data have gotten analyzed. On the children, we also have health information, and fortunately, we have measured heights and weights. So we do have that little glimmer of hope for those of us who are interested in health and have to publish in the health literature, where it gets highly criticized if you've got self-report data. We have this sort of measurement piece. Let's just go through this. So here's just a little bit of data about so most of the time that I'm doing these analyses and the reports that you're going to see up here when I pop up results, I've got about 3,000 kids born to, and I didn't give you an exact number, probably born to about 2,300 women. There is about 1,800 whites and about 1,200 African American, and a lot of my work tends to only look at the daughters because I do maturation issues and menarche in the daughters, and so I'm funded right now to look at mother-daughter dyad work, and so because one of the studies is going to focus on behaviors during pregnancy, and again, because height and weight was measured, we really started out with this data set to encourage and to be sure that we had credibility in the health literature with measured heights and weights. In terms of the moms, in terms of where they were, remember this is a cohort that was born from 57 to 64. Their weight states are much lower than our current weight states. this is just to try to give you a sort of visual, I'm a visual person, idea about this intergenerational data collection. And so we have, in 1986, we started collecting on the kids. I should have put the young adults on here. I didn't even think of that. So if you think about a mom who's going to have a child, let's say here, we actually have a fairly good pre-birth history of this woman in terms of the kinds of data we have. It may not be completely the kind of data we want. And then onward, we get these identical data from both the mother and the child assessments. I did mention in some of the data results you're going to see is on cognition and behavior. Not only did they do the home scores, but they have done cognitive tests on these children, again, starting, I think, at age 4, no, I'm sorry, it's starting at age 5 up through age 14. And behavior information. So I'm going to go through a series of 4 studies real quickly, just to give you an overview and show you the kinds of things we found and how that has been driven by what's been happening in the science, and at the same time has driven our thinking into where we are currently. So when we started this in 2000, and I got to know the data set, and that wasn't an easy task, as you can imagine. Obesity was, as it is now, but even more so as in the literature, in the popular press, is the oncoming problem, right? And so one of the questions we wanted to ask was, what drives obesity in children? And how is that related, sort of as a function of maternal interuterine risks and pre-pregnancy weight status? Now, this is fairly common knowledge now, but at this point, this question was not yet well established. At that point, I think both my collaborator and I were thinking that it was going to be driven by socioeconomic status. Okay. And while in some ways you can say it's driven by socioeconomic status, what it's really driven by, that we tried everything that we could try in the models to see if we could lose these associations, what it's really driven by is pre-pregnancy weight. Now again, this is pretty well known now. But when we first were doing these analyses, this paper appeared in Pediatrics in 2005, so our analyses were going on in 2003. This was really something that wasn't quite yet established. And I sort of highlighted down here, and I'll go through these in a minute, and since this has been published, this association has also been well established, and that is that there is this effect of smoking during pregnancy on the weight status of kids from early on. It's likely due to that sort of interuterine programming, maybe having something to do with undernutrition or restricted blood flow through the uterus. Again, those of you who are midwives will have a better sense of this in terms of the effect of the nicotine. And in our data set, I'm not going to give you all those data, but our data set also shows, just like I think most data sets shows, babies born to mothers who smoke are smaller. Our babies that were born to mothers who smoked were smaller, and that there's a smoking risk. If the mother smoked, your child has a higher risk of becoming obese. Now, we did a dynamic model that looked at different ages, and so T1 is at 2 to 3, and T2 is at 4 to 5, and T3 is at 6 and 7. That's what's nice about this data set, is that we could look over time. And what we saw is that the risk actually goes up. It's not, we didn't see it at 2 to 3 for the overweight moms, but by the time the child was 4 to 5, there was a higher risk that they would in fact be overweight. And at 6 to 7, I'm not going to go through all these data. There's also some other work that we did in this paper that shows that that the children who became obese stayed obese, children who became overweight stayed overweight, so that it in fact, there's a lot of, what's the right word, continuation of a problem that begins early. This we just conditioned on whether or not the child was overweight in the prior period, and so if the child was overweight at 2 or 3, what's the likelihood that they continued to do, and this is just whether or not we used measured weight or not measured weight, because there were a few that weren't measured. Again, the only thing important here to see is we continue to get this increasing odds. Now, we had a lot of other controls, as you can imagine, in these models, and we really couldn't budge these odds ratios. We had a lot of other, we had mother's education, we had some economic data, nothing reduced or, changed these odds, even minutely, I'd have to say. I mean, maybe at the second digit, we would get some change. So it began, so here's where these results surprised me a little bit in 2003. I wasn't really expecting to see this. We also didn't have, with these data, an effect of weight gain during pregnancy. It seemed like it really was the pre-pregnancy weight that's what really mattered in terms of the long run. So that got us thinking about, so notice how early those things happened. And at this point, I really wasn't thinking about life course. I really wasn't thinking about 0 to 5. I wasn't really, I was really interested in race and economic differences and health equity and health disparities. These results sort of, and what was going on, I think, across other studies, things across other longitudinal studies really got me thinking about, wow, what's happening here? So at the same time, we also wanted to look at the other issue that was pretty much being discussed at the time was the earlier age of menarche in the U.S. Girls. And I don't know if you've had a similar sort of decline here in the UK with respect to maturation happening earlier and earlier, and age of menarche or first menses happening at an earlier and earlier age. And so we decided we wanted to look at timing, growth, and maturation sort of as a function of obesity, because a lot of anecdotal information at that time and some of the work from actually the 70s suggested in order for girls to get their first period, they have to have a certain fat mass. And so, the thought at that point is that the obesity epidemic was probably driving these earlier ages of menarche, or at least there was some question about how that went. So it was here, oops, sorry, I don't want to go through all this. So I got, so by the time I got here, I was sort of interested in this life course model. And so you've probably seen this in various versions. There's a lot of different ones out there. This one is one from Halfin and Liu, but there are many different versions of this that just suggest, again, that you have these trajectories throughout childhood, and what happens at any particular point, especially if it's what's referred to as a sensitive period or a period in which there's a lot of biological plasticity, you might get longer term effects of that context. And I think the challenge for us is to figure out how we use this kind of model to mitigate and use this knowledge with respect to improving outcomes and sort of moving the trajectories up. So we're already there. So here's just what we found. And we were, again, very intrigued by this. It's not going to be intuitive here, so let me just take a minute. What we did, and again, because of the difference in race, we looked at growth curves for African Americans and whites. And this is early, mid, or late definition of age of menarche. And what we did was to do quartiles that were race specific. And so this is the bottom 25th percentile, this is 25 to 75, and this is the top quarter. Okay? So, And you can see what we did was put the age of menarche and, I'm sorry, this one's the sort of differences of when we get differences by these groupings of menarche. When do we get differences in weight? Okay. So again, a little bit surprising in African Americans. In girls who went on and had either an early or what fell into that mid-region of menarche, we already had growth differences at 3. Okay? Again, sort of a slap in the face. We get these growth differences beginning probably before age 3 that in these categories of early, mid, and late menarche. So here, I'll trace this out. These are the girls whose menarche was early, the bottom 25th percent. They were, as you can see, from beginning heavier. Again, the statistical significance doesn't come up until age 3. And then there's a difference between the late and mid by I think it's actually by 5 years. Again, very early. So this is influencing, again, this early life. For whites, we get the curves are very similar, except notice that the BMIs are higher in African Americans. And the difference across all 3 groups isn't evident until age 6 in whites. But it's still, it's like, wow. By age 3, 5, and 6, we've got these growth trajectories already established. Now, whether or not it's obesity or there's a common cause, we had no data to really tease that apart, other than, again, this gives us a glimpse that clearly obesity isn't a problem that occurs after early menses, which is what was still being debated at that point. It really has to do with something that begins much earlier than that. So that we've already gone through that. So so we're very interested in this whole notion of maternal obesity really affecting the child's obesity, maybe also affecting what's happening with the girl's sort of physical maturation around menses. And then I have had the pleasure of having just a terrific set of doctoral students who have worked with me on this. And this is Rika and I's work in this area. And the other area that I've gotten very interested in, I talked to a couple of people ahead of time, I've gotten very interested, it's also been a big part of what's been going on in the literature, but on the sort of metabolic milieu that occurs intrauterine with obese moms. And thinking about obesity as an inflammatory disease, and if you layer on top of that gestational diabetes, there was a lot of evidence now building about what that does to the fetus and what that does in terms of pancreas growth and their ability to manage major organ system development. But my student was really interested in brain development and wanted to know whether or not these metabolic differences in overweight and obese pregnant women not only impacted their sort of major organ system, but what its effect was going on in terms of the brain. And again, she was influenced by some work that was going on at that time that suggests that there's higher rates of Alzheimer's with people who have type 2 diabetes, because they're beginning to think that also has metabolic consequences. So we began to ask the question of whether or not these metabolic changes have cognitive or behavioral impact in the children. Okay, so this is sort of the maternal influence across generation. So there's pretty good evidence. Our data suggests that there's great evidence in animal literature, if you look at it, and other studies about this maternal pre-pregnancy obesity affecting obesity, metabolic syndrome, and type 2 diabetes. But what's even more interesting is, and I'll walk through this, are these results. So this is, again, using the same basic data that you've just seen. And we have, as I said, we have some cognition data on these children. These were taken from the PIAT, which is a standardized tool for understanding reading and mathematics scores. We did this at age 5 to 7 because it was the first time the instrument was, I think it was age 5, I'm sorry, 5 and 6. The first time the instrument was given to the children, and we were trying to avoid a lot of school effects. So we really wanted to try to capture it. So we would have liked to have had it younger. We didn't have it younger, so we did it here. But what we found, or what Rika's found, and it's coming out, so her last name is Tanda, if you're interested in, I can't remember, it's Journal of Maternal Health, I think is where it's coming out, is that obesity, lo and behold, does have an effect on cognition in children, and it's negative. So that both the reading and the mathematics scores are lower in children born to obese mothers. Now, we had the same question because obesity tracks, at least within whites in the U.S., it doesn't track this carefully with blacks along economic lines. And so whether or not it's just a proxy for, is obesity just a proxy for some other sorts of issues? Well, we have lots of other ways in which other things we put in the model, and all of those things are in fact what you would expect. That is higher home scores. Remember that instrument that we use that we can test what's happening in the home, including reading and those sorts of things, have higher both reading and math scores. Income, we get an increase. Mother's education. The NLSY has the AFQT score, which is the Armed Forces Qualifying Test, which is an ability-based test and somewhat like an IQ. I mean, these things all tracked exactly how you would expect. That is, enriched homes have kids with higher reading and math, but when you control for all of that, okay, you control for all of those, what we would normally think of as socioeconomic variables, we still get this pretty significant decrease in reading and math scores. Well, I'll just leave this here. Let me see if I can go back. Yeah, oops, well, there we go. Okay. Interestingly enough, there is a follow-up study or a similar study that just is coming out in the February issue of Pediatrics on the Millennium Cohort UK study, which has found the exact same thing. They have the same, almost identical results. It's a different, they have a different cognitive test, and I don't remember off the top of my head what their cognitive test is in the Millennium Cohort study, but they found the same negative effect of maternal obesity on child's cognition. So there's now been, I think, 4 studies that are out. 2 are which are, one was only done with African Americans in the U.S. Probably Rika's study and the Millennium Cohort study is done with the largest national sort of cross-sectional group or national group with, I mean, remarkably similar findings. But the whys and the hows and all of that, we don't really know. Again, this is more epidemiological observational studies. The biologists have some explanation for this. We have some explanations in the paper, but all of our explanations actually have to come from animal model work in which if you look at feeding, it's rats, and so, you know, I guess there's some damning evidence about using rats as your model, but you know, if you feed rats high-fat diets, and then follow their pups, I believe is what we call them, and put them in learning mazes. Those pups that were born to high-fat dams, you know, during pregnancy, do worse in learning mazes, and so, you know, there's some ideas about, again, at the cellular level, what's happening around glucose and insulin sensitivity, and actually, depending upon when the insults occur during pregnancy, the neurons and dendrites development. And so there's been these cross-sectional brains that will show that in these mice, or I'm sorry, rats, that they've got actually less brain volume. So again, this is just beginning to be, I mean, it's not anywhere close to being understood, but interesting finding. She also looked at behavior. We looked at behavior with the BPI, which is just an inventory that's asked of the mother. And in here, all I can say is we've got questions. We've just, these data, we just sort of finished looking at them. We have pretty significant results that suggest that for obese white women, they have children who have greater behavior problems. But we also checked, and this tracks very well with disadvantaged women. So in some sense, for white women in the US, obesity is a sort of secondary marker for disadvantage. It's not that for black women. Oftentimes, African American women, the most accomplished are at least at equal weight or heavier. They don't have the same sort of socioeconomic gradient, at least at in this age group, that white women do. There's some evidence that it may be changing in this current generation of African Americans, and that they are beginning to assume the ideals of thin bodies as they go up the economic ladder. But that wasn't in these cohorts, and so we're not quite sure what this means. Is probably where we leave this. There's the UK. And let me just mention this because I find this one particularly interesting too in terms of using an intergenerational cohort. The last study, and we're waiting to hear whether or not this is going to be accepted, I was interested in understanding the health of the young girls when they entered adulthood at 17 to 24 compared to their mothers when they entered adulthood at 17 to 24. We didn't have a lot of measures in which we could really ask this question, but I wanted to know whether or not the health was getting better or worse. We all sometimes are under this belief that the health is getting better, right, of our children, and that's our hope, is that that generation is in better shape than we were at that age. And I wanted to understand what the racial differences were. Well, unfortunately, our data would suggest, one, that our daughters, I'll put it in my sort of, are in worse health than we were when we were entering adulthood. And it really, on the kinds of things we have to measure. And this cuts across all economic lines. So what this says is that, so we had no height difference. That means the daughters are about the same height that their mothers were. But on average, these daughters at the same age that their mothers were are entering adulthood 14 pounds heavier. And African American daughters are entering at 21 pounds heavier. That's a pretty significant difference at 17 to 20. And I didn't bother putting up here how many of that, and that doesn't take women who are underweight into a normal weight category. This increases the percentages that fall into the overweight and obese category by a lot. So these women now are in high-risk categories. These are just the BMI differences. And most alarming, if you understand early age of menarche as being a risk factor for midlife chronic disease, which is, there's evidence for increased breast cancer, some metabolic diseases for women who experience early menarche. This is pretty incredible. The African American girls had their first menses about 9 months on average younger than their mothers. And for white women, it was about 3 months younger. And here, gives you a sense of, we had fewer here because we had to have dyads. We had to have all these data on both groups. And so we had about 1,300 whites and about 1,100 mothers. And so I'm also interested in trying to now, I put it like this, follow them along to see how the daughters' lives look in comparison to their mothers' lives, because we can do that. Again, it's a challenge methodologically. And it's a challenge for my brain to try to keep this straight, right? And then if we layer on a third, all we have on the third generation is their birth weights. We haven't talked any funder into letting us fund this group, but anyways, I think. So this is just the sort of end of the talk kind of thing, and I've really gotten interested in transitioning more into how we can use this body of evidence now into changing practice. So I'm sort of shifting gears a little bit. Because of my broader health equity and social determinants framework, I think a lot of this has to be at the policy level, which is what I talked to Ruth a little bit about. And I think we have to be cautious that we don't, these data don't get framed as individual responsibility issues and blaming particular people. I think the other thing that we've learned over the last 10 years is these things are socially patterned, and how you end up has a lot to do with where you've come from and the kinds of influences and individuals that you've been exposed to. I don't think we really understand what an ideal child health trajectory would look like, but that's certainly what I would like to think about. You know, I'm still amazed in pediatric practices in the U.S. that they're not doing more to monitor growth trajectories. All they'll do is do heights and weights without trying to figure out, you know, where they've been and where they're going, kind of thing, or be able to make some interventions around that. I think we have a big opportunity here between our current practice and improve the lives of a lot of children. So I don't think this life course model says that it's all determined. I think what it says is that we start out with a different set of risks individually, maybe across groups, and we've got to figure out ways in which we've got interventions to address each of these. It may be that interventions will have to be targeted to groups who have different sets of risks early on. So I mentioned a couple people. I've gotten really interested in how you can do type 2 diabetes primary prevention if you take women who've had gestational diabetes, enter them into some, so sort of an intergenerational thought, enter them into some programs early on, or at least follow them, because we do abysmally in the US at following these women up. But also then if we could add on an infant program that would allow us to do primary prevention, because we know of the increased risk that these infants have because of type 2 diabetes. It would be a sort of an ideal life course intervention model that could tell us whether or not we can do better by them. You know, we still have many providers in the US, unfortunately, that will tell women who've had gestational diabetes, and if they are in fact have normal glucose afterwards, they don't need to worry about anything. I mean, it's just incredible that they don't then do some follow-up teaching about how their risk have now increased dramatically over the next 5 to 10 years for the development of type 2 diabetes. Really big missed opportunity, I think, in terms of intervening. So why am I here? One, I've been interested in following both what's happening with the support in the Scottish government around early life and those sorts of things. And I've done a lot of reading about the GUS, and so I was intrigued especially with the data they have from 0 to 5 and how that's influencing.
So, Pam, can you just, I don't know if everyone will know what GUS is.
Oh, I'm sorry. GUS is the Growing Up Scotland longitudinal survey, which, I think the first birth cohort was in 2005, and there was a second birth cohort in 2010. And along the way, there was a cohort of younger children enrolled, which I don't think they're following anymore. So I'm not an expert. I've just done lots of reading. So, and one of the pieces that they appear, I'm here to learn, so I would just say, a lot of questions and interest in how you support parents and how you help them understand and move kids up that trajectory as opposed down that trajectory. So I think there's information that can come out of the GUS that can help us all try to help parents help the kids move up the trajectory. I think that's where all parents want their kids. They want them to be going up the health trajectory, not on the downward level. So I'm interacting with some folks while I'm here to talk about that, just to sort of really interested. And as I said, I think it's got to take a broader sort of public health, social context view, and so I'm here to learn. This is my collaborators, and Pat is the economist who's been so helpful. It's a very, for all the talk about interdisciplinary teams, this really is, it's probably the first interdisciplinary set of, we all come from it takes us sometimes 2 weeks to figure out whether or not we're talking about the same problem because we all come with different languages. I mean, it gets better over time, but boy, that's tough work to do. And I said to you, if you're starting out your research career, these interdisciplinary groups take a lot of effort and time, and hopefully your institutions will be kind to you. The U.S. institutions are not that kind to early investigators, so I worry about what we're doing to our young by telling them they have to be interdisciplinary, yet at the same time knowing that it takes, you can't do community work, you can't do interdisciplinary work on the fly and do it quickly and do it well. I think we have a few minutes for questions. I'm sorry I talked for the full hour, but I appreciate your attendance and interest, and so I know some of you probably have to rush off to class or something. Thank you very much. Any questions? Yes?
No, correct Macintosh. There was a clear link between maternal weight obesity and the children's weight gain at different ages following birth. Did the maternal weight gain continue to increase as well following birth? Obviously was there evidence to suggest that?
We were able on some models to put in whether or not she continued to gain weight, and there's a secondary paper that takes these kids up through I think 12 to 13 early adolescence, that then also controlled for the mother's own weight gain from 0. So we can control for the mother's weight gain from 0 to 12, that is when the daughter's 0 to 12, and look at, and it doesn't knock out the pre-pregnancy effect. So of course, I mean, I think there is some effect, but it doesn't, it's not wiped out. It's not simply because, I mean, here's what my take on it. It's not simply because that environment may be conducive, which I think it probably is, but the work is building around the idea that there is something in utero going on metabolically that sets these fetuses up. Whether or not it's this cutesy, thrifty gene hypothesis, which says, or something like that. I think it's complex. I think it has something to do with what genes get turned on and off in terms of epigenetics. From everything I've read, what I would say is we're not quite sure why, but I think the evidence is coming around that children born to women who've got metabolic, whether it's obesity, type 2 diabetes, that has an effect biologically on the fetus. One of the big areas that people are now trying to think about how you do research, because it's so hard from an ethical standpoint. We also know that 0 to 1 is a highly, it's a critical time in plastic in the sense that biology is still possible to change. In some animal models, they've been able to show that depending upon the feeding from 0 to 1, you can actually alter this intrauterine trajectory. We don't really know yet. And so I think that's really where we've got to push the research. We've got to begin to ask questions about how you get at that and how you, but it's very hard because you can't randomly put, kids in these areas. So it's what's been done is these animal studies that would suggest, but the other thing, I was at a breastfeeding with a group of nutritionists who were very much into breastfeeding, as you can imagine, and learned all sorts of things that I didn't quite, understand even as a nurse, encouraging breastfeeding, where they talked a lot about, sort of the time and what type of milk comes down, at what point the baby feeds or doesn't feed, whether or not the mother expresses and puts it in bottles, what gets left in the lining of the bottle. now is a very interesting question that nutritionists are concerned about. I hadn't ever heard about that. But that there are certain of the components of the breast milk that may not out of a bottle. So even if you've sort of breastfed via a bottle, you may not be getting the same benefit nutritionally. And we have no idea. I mean, even if we have breastfeeding data for what we don't know is how often the mother expressed that and did via bottle versus actually latched on and breastfed that way. So it just says there's a lot we don't know, but there's a lot at stake. And what it's, so that's why I've got interested in the 0 to 5 and how we can figure out ways to mitigate some of these. What I think we know are risks. Whether or not these risks have to be determinate, we don't know. And I think we've got some indication from animal studies that they don't have to be determinate. We just don't know how to switch them back off. So I think that's really what we've got to work on.
Does breastfeeding help at all? In terms of if pre-obese women are breastfeeding, did that have any effect on obesity of the children?
The literature's a bit mixed on this. Most would suggest or like to suggest that it is protective. In one of our little studies, we did do this very gross measure of breastfeeding. As I said, it was just a yes or no. We don't have time. We don't have bottles. We don't have a lot of things one would like. We did get a protective effect. That is, the children were less heavy if their mothers were obese. And so it, in some sense, seemed to have a different effect in terms of being protective if the mom was obese. There's also, we haven't even touched on the issue, there's all sorts of gender issues here in terms of just sex hormones and how those can play out over this early life period. But there's lots of good evidence that breastfeeding is the right thing to do. What we haven't figured out, as we talked about earlier, is how to support women to do it. And it may be, it's not going to make them heavier. Let's put it that way. And there's some evidence that would suggest that it will help protect them. Some of that thought has nothing to do with nutrition, but has to do with the fact that this idea that infants learn self-regulation by breastfeeding. So it's up to them to latch or not latch, and so they're learning very early how to self-regulate their diet intake. And self-regulation then has a lot to do with later on obesity control or weight control as you age. So.
And there's information about breastfeeding and diabetes as well, protecting the baby from diabetes. It's about priming the baby's metabolism to work properly.
Yes.
Because it's all you've got your growth hormones and
that's right.
other factors in breast milk, not just nutrition.
No, that's right.
So, it's not an inert substance that gives nutrition, it's more than that we don't understand.
We don't understand. There's been just one quick study, and I even hate to mention it because it's the only study I've seen, and it may turn out to be completely, just a fluke, that looked at breastfeeding in offspring of gestational diabetes women, and that the composition of the milk in those first few hours actually may be harmful. But again, I wouldn't even go there. It's just one study. It may be an odd fluke finding that won't be held up. But I think the point is that there's an interest in understanding the milk composition across mothers, in particular for women with gestational diabetes, in terms of what's in that breast milk and does it look different than a non-diabetic mom. So I think that's where the research is going.
And it also protects the mum, because if she breastfeeds,
absolutely,
she needs less insulin, so
yes.
it's metabolically regulatory for the mother as well.
And she'll lose weight faster.
Yeah, well, women also are
Yeah.
The other thing I think is interesting in terms of the early years is there's been some work in Scotland done about stress, maternal stress, and the hormones and how it affects the brain development in the baby, and kind of if the mother's low level continuous stress, the babies are primed to be more stressed themselves, but also react to stress, so you get more of the ADHD style of behaviour. But with really good early years parenting and support, you can offset those. So a lot of what you've said about feeding and obesity and all that, with good parenting or feeding or diet or whatever in those early years, you can mitigate some of what's already happened.
That's right. And we need to know
That's
much
it.
more about
Yeah,
that.
So it's always, it seems to be that we're never knowing where to start. You start before pregnancy, during pregnancy, after pregnancy, because it's a continual loop. But if you think, right, let's focus on those early years,
Right, right.
because we've got to pick somewhere to start, and there is good evidence for that area.
Yes, and I would say, Ruth has sensitized this to me, but the sensitive periods aren't just those early years. So another very important set of critical times is transition into adolescence, because there's so much hormonal and biological change that it clearly, and I think in terms of, I think there's more research on the early years than there is at that metabolic and hormonal period in terms of understanding what's happening with those adolescents. We need, I mean, in terms of life course, everything I've seen in life course in the US too has been focused on the early years. I think we need to sort of think about other areas.
Would your data set not allow for some analysis, not the development, but of sort of risk behaviours and things, and maybe associations with menarche and...
Yes, yes, we could look at risk behaviors. We've got, so in the young adults,
in the young adult ones.
Yes.
Has any of that work been done?
We haven't done it yet. I think there's been some that's been done by others, but you're right, that risk behaviors, we have good risk behavior data. Again, if you believe self-report data. Yeah. Yeah.
What's your risk behaviour, sorry?
Well, we've got smoking, we've got alcohol, we've got marijuana use. The hard drug use is pretty small. Again, when you get these numbers, but we've got those sorts of risks. We've got early pregnancy. So, you know, and what's nice from a researcher standpoint is, you know, you can follow generationally the pattern of mothers who gave birth at a young age, these daughters are giving birth at a young age, that sort of thing.
So is there a relationship to that as well?
Yes. Yes.
Mothers will give birth at, like, in their teenage years, and then they have a daughter
Who also
does the
yes.
same thing?
Yes, yes, yes. So risk behaviors, and we have, and there's been, and I'll have to look, there's been some folks, and I don't know what they found, have tried to look at the adult parents' risk behaviors aligned with the adolescent risk behavior. Because remember, you've got this data set that goes along on the mother, and you'll know whether or not the mother drinks or smokes or, you know, at intervals. I don't think they ask those every 2 years, but you'll know whether or not she has engaged in risky behaviors, and you can then track to see whether or not that gets passed on.
You know the Millennium Cohort study, is that similar in terms of taking a group born, say, presumably 2000 and then following them up? Is that what's happening with that? Or is it
that is, but no, the Millennium is a longitudinal.
Yeah.
And it's a UK-based, right? Yeah, it's a UK-based study, and that's probably, thank you, about as much as I should say about it, because I don't want to misspeak. Yeah. And I don't think, the unique thing about the NOSY, I think, is that we have the parents.
Yeah, it's fantastic.
I mean, you've got again, we don't have a lot of things that people want. And there is an effort that on the young adults to do some biological, to pull cortisols or do something, but it's just mired, absolutely mired in the political process. I mean, it's been funded by NIH to go out for data collection for the young adults to collect some biomarkers, but BLS is not very happy about it, so I'm not sure where it's going to go.
Is it open access, the sort of the data? I mean,
yes.
So any research
you can go on. Yes, you can go online and get it. Now, what you can't get access to is the geocoded data.
Right.
The geocoded data is confidential. In fact, when we started this, it turns out this data set's housed at Ohio State. So, and it's been there since the 60s. And there was actually some cohorts before this. And at one point, we had a contract that allowed us to do, if you were at OSU, you could do the geocoded, you could use the geocoded data. That ended in about 2004. And so if we want to do the geocoded data, even though my Pat, my collaborator on this, actually geocoded the data. She can't access it for research unless we go to Washington. So it makes for the neighborhood work. We've done one study on neighborhood work, and it's just too hard. It's just too hard to try to do it. But no, it's open access. You can just go to the BLS website. There are lots of links to it. It's not the easiest data set in the world to use, as you can imagine, but it makes for a nice PhD project.
And they're so desperate for people to use their data too.
Yeah. I'm sorry?
They're so desperate for people to use their data set.
Well, I hope to be able to look at it. So, yes, yeah. I mean, I'd like to do some parallel things, even though it's a little worried in terms of timing. You know, my kids. The kids in this are going to be about 10 years younger than the Gus kids. So, and then the question is, can you really make comparisons? And
I want to ask you a bit about the home observation studies that you've done and what you know about the Gus studies. And are we looking at the same kinds of things in homes?
Again, I haven't drilled down that close. I'm going to hopefully have some conversations. There are some constructs that look the same. I think probably the actual data element that goes into making, like, let's say, a nurturing or a hostile environment, I think those data elements are going to be a little different. But whether or not you believe the way those environments are measured, and then the question is, do those environments suggest the same sort of outcomes? So, yeah. Thank you all.
Thank you.
Thank you.
You use the Gus data at all?
No, it's open access as well. Gus data.
Well, some of it is, yeah. They just, you certainly only have to get in touch with them to get put into the fund. And that part of the funding is, one of the conditions is that they encourage people to use it, these large quantitative sets. And they are getting quite anxious about people not using it enough. Get in there. Yeah.
Now, have you used it?
No, because I don't do quantitative work.
Okay.
I do qualitative work, but obviously I need this for context, and that's particularly interesting.
Yes.
And I do contribute. I'm on the sort of the panel where they ask for questions. Oh, okay. They have a sort of big range of Scotland that they send when we need next level questions. The kind of work I do, I work with early years young children.
Okay.
It's pretty difficult to do with that kind of data collection. But they are a really nice open set of people.
Yeah. No, I mean, there's only, you have to ask questions that the data can give you answers to,
Yes.
and they're not going to be the only answer. I mean, they can, I like to think of it as a way to point us in the direction for the next set of in-depth.
Yes.
So.
Well, going to be working on Augusta looking at childhood obesity.
Oh, interesting. Good. I just get so depressed by that. Well, no, there's data. Stuff about how it just seems, how defined some children seem to be by the circumstances.
Oh.
So, yes. Thank you very much.
Thank you. No, it is. That's why I think we have to be careful to think about, well, really what we need to do is so I'm trying to reshape my own thinking and to think more around resilience and nurturing and try to see in light of situations that might be disadvantaged, does nurturing and resilience protect?
We're about to do some work on, sorry. I'm Christine Stigman from Education.
Oh, right.
I think it was you I emailed to say. Yes. So we were about to do some work on that's another way in which you can influence a child's everyday experiences at a very young age. And it is being used for that particular kind of child available as well. It's being used as kind of an intervention tool.
Yes.
For children, families express some mistakes, some immediate ability. And look at some children and these kids have an input with their child mind with them and see how that compares with what we think is the positive nurturing behaviours. Because it takes some examples from some of that sensitivity stuff that big studies done in the NICH studies in the States.
Yes, and you're probably familiar with
I thought she meant sexual.
Yes.
Then what's the set effectively bar things? And
Yes.
those are the things that
Absolutely. But it was their product.
So the business, I think, and they went all of it places.
Experiences. Very much.
Oh, yes.
Visits.